Good morning, good afternoon, good evening, everyone. Welcome to another one of the Gladstone Amplified Race and Reality in STEM series. My name is Dr. Manu, Platt. I'm a professor at Georgia Institute of Technology at Emory University and also on the planning committee, and just happy that you came and showed up for another one of our wonderful presentations. The Amplified webinar series aims to give a national platform to speakers and have candid conversations around race and diversity in the STEM field. It was launched in 2020 as part of Gladstone's commitment to diversity, equity, and inclusion, and is hosted in partnership with Georgia Tech, my place, the Molecular Engineering and Sciences Institute at University of Washington, and the University of Texas at Austin. And so we hope these discussions spark change throughout the sciences and help to keep the Black Lives Movement at the forefront throughout 2021. Just a few quick housekeeping notes before we get started. This event is currently being live streamed on Facebook and is also being recorded and will be posted on YouTube later. You can submit questions anytime during the talk by using the Q&A button at the bottom of your screen. And if you're watching on Facebook Live, submit your questions in the chat and our moderator will share them with me and with the speaker. We'll try to get to as many questions as we can after the session, after the speaker. So please stay on board. And if we don't get to all questions, you can reach out to Dr. Akintobi directly after the webinar. So now you see my background behind me. I've got the Morehouse Chapel because it is my great pleasure to introduce Dr. Tabia Henry Akintobi, who is a professor of community health and preventive medicine and the Associate Dean of Community Engagement, as well as a principal investigator and director of the Prevention Research Center at Morehouse School of Medicine, which is across the street from Morehouse College, my alma mater. Relevant to these efforts is her demonstrated excellence in community-based participatory research, community-engaged public health practice, and experiential learning among trainees across the health professional career development pipeline. Dr. Akintobi received her bachelor degrees from the University of Miami and earned both a Master's of Public Health and Doctor of Philosophy in Public Health from the University of South Florida's College of Public Health. So in this discussion and call to action, Dr. Akintobi sheds light on the consequences of the pandemics and their root causes. She also proposes a path forward to prepare learners and leaders to advance population health through the past and the pandemic. And so it's a topic that's relevant to all of us. I look forward to hearing and learning from you. And I turn it over to you, Dr. Akintobi. Thanks for coming.
Thank you so much, Dr. Platt. This is just an absolute privilege and honor. So thrilled at the opportunity to shed light on what I'm learning, and hopefully all who are participating as current or future learners and leaders will have some food for thought as we continue to navigate our path towards recovery and resilience through the pandemic and beyond. So I want to start by grounding us in a bit of what Dr. Platt shared in describing the lens I look through is that of public health and health equity. And I think really aligned with the conveners of this event. We certainly are looking at intersectionality, not just with STEM, but the connections between STEM, what's happening with the pandemic, and what the path forward should look like. So, when we think about societal issues as well as health issues and health equity, it's important to just remember our foundation, and that is that in the US, we spend more on healthcare than any other developed country. And chronic diseases really dominate healthcare costs. So things like cardiovascular disease, diabetes, asthma, among others. And when you hear those three chronic conditions, they should connect your thinking towards those illnesses that disproportionately create complications, hospitalizations, and death related to COVID-19. So those things are connected to our healthcare costs. And more importantly, people spend probably 97% of their lives outside of a doctor's office if they have a primary physician. And so what we know is that social, environmental, and economic issues are the root causes of healthcare costs, as well as expenditures. And they're also a part of the reason why the health conditions happen anyway. So important to note, if you don't get anything else from what I've shared, it is not the individual's sole responsibility for making their health ideal or creating their best life. Their health is also shaped within the context of social, environmental, and economic factors. So the title of my talk is what the pandemics have taught us, right, about research, leadership, and STEM. And so I want to be clear, when I'm talking about the pandemics, I'm talking about at least two that folks are familiar with, clearly COVID-19. The second is that of social injustice and unrest. So COVID is new. Social injustice and unrest is not new, but has been inflamed at the same time that we are navigating the pandemic. And then the third one, which is the silent one, that a COVID test and a vaccine shot cannot fix unless we're intentional. And that is the mental and behavioral health aftermath related to the pandemic. What does it mean, not just for communities that are disproportionately affected, but if you consider yourself a leader, whether the leader of your household, certainly you should be the leader and governor of your own health and behaviors. But even if you're leaders in other spheres, your mental and behavioral health matters. And we all have been touched by this pandemic, whether we contracted COVID or not. So I want to be sure to emphasize the third pandemic of the mental and behavioral health aftermath related to the first pandemic of COVID-19. So when we think about those social, environmental issues that are at the root of why health disparities and inequities related to COVID-19 exist, I want to talk about it in terms that are broader than health, but intrinsically and directly connected. First, poverty hurts. And poverty, or income inequality, that is the root of poverty, places children and the adults that they become at a disadvantage. And so here you see on this slide how low-income children or children living in poverty are cognitively, are more likely to be cognitively and developmentally behind or have health issues that have been undiagnosed. They're more likely to be in schools where there has been a lower or political disinvestment in their quality. They're more likely to not complete high school and to enter adulthood with lower levels of education as well as achievement. And I say this just in speaking of the numbers. We know many of us and many of you have come from low socioeconomic status backgrounds and have been resilient and have excelled. And so all of the interrupters of that path to disadvantage or less achievement, it requires an interruption. And that's a part of what I'll discuss today. But just based on the statistics, when we think about who is more likely or less likely to succeed, just based on those facts, those in poverty are more likely to be disadvantaged and be on a pipeline to poorer health and less achievement. But we know that the numbers are not enough. We know also that education and health are connected. And so it's not just about the individual, but it is also about the fact that poorer health can put education at risk, and certainly they can contribute to you being less likely to have health insurance, being less likely to have a job that allows you to be able to shelter in place, and more likely to be on the front line. And I use that term very loosely because in our COVID era, when we think about frontline workers, we're often thinking about health professionals who are putting their lives on the line, but people who are working in service industries, whether they be janitorial, food, or otherwise, they're also putting themselves on the front line and have been those that have been more likely to be sick, be hospitalized, and die related to COVID. And so some of it is about educational opportunity, access to health insurance, the ability to be able to do those things that many of us have to keep ourselves protected from the onslaught of COVID. And so this map was developed long before COVID, but it's just a demonstration of the connection between place and advantage, right? So I am at Morehouse School of Medicine, and this Nexus map shows you where food stamp recipients live per square mile. They're actually in and around Morehouse School of Medicine is where you see the black shaded area. And of course, there are others also, but I'm talking about home now, right? And so that place-based reality in terms of social status is directly connected to the number of low birth weight babies per square mile. So this is just an example of how a social investment, a social reality is connected to a health reality. And that's just one example that also layers nicely now onto the degree of COVID positivity within that same community, which is high, and lower vaccination rates. So here, place matters when we think about health outcomes, and certainly risks and resilience related to COVID, among many other things. So probably for the first time ever, there has been probably the greatest understanding of what health disparities are. My parents finally know what I do. They know that I cannot prescribe them medication. And so for quite a while, they didn't get what I do as a social behavioral scientist or someone with a public health background. Thanks to COVID, they now get it. And so people may not know the term health disparities, but they're now understanding it when they see how COVID has disproportionately affected certain communities in comparison to others. I intentionally tried to use the term disproportionately impacted communities rather than vulnerable. So when we think about the importance of language, vulnerable connotes that the individuals are the ones that are responsible for the solutions. Disproportionately impacted is more objective because it speaks to the number of deaths, the number of those who get sick, and those who die as a result of COVID or anything else. And so I also challenge you when we think about language and health disparity populations that we consider using the term disproportionately impacted. So the National Institutes of Health has included their designated list of populations that, whether it's COVID, diabetes, asthma, etc., these are the population groups that, depending on the issue, they are more likely to bear the burden of poorer outcomes. And so you may see some population groups that are not included here, connoting that there is an important necessity for us to acknowledge intersectionality. So if you are African American or Latinx and are a member of the otherwise abled population, you have unique experiences of the healthcare system, of social injustice that I might not. If you are a sexual and gender minority and live in a rural community where there might be less understanding or access to a healthcare provider who knows how to appropriately engage you, your experience of COVID or another health issue might be very different. So we cannot look at these groups, some of which define and describe us as a monolith, but the intersection of experiences are what we must understand to be able to respond when we think about both communities, but also really promoting STEM opportunities that acknowledge the differences and the opportunities that individuals representing them bring. And so quickly, just to make sure we nod this important framework, Dr. Kimberly Crenshaw was one of the first scholars to speak to the realities of intersectionality. And this is a framework, as you can see here, that acknowledges that we are defined by multiple identities and experiences that shape our understanding and our experience of systems of oppression, domination, and discrimination. So my experience as a child of immigrant, as a female and a Black female is not the sum of being Black and female. There is a unique experience that must be understood and that must be appreciated in the STEM field to create new innovations, ways of thinking, and empathy for those that I serve, as well as those that I seek to bring to elevate voice, opportunity, and interventions for. And so, I want to be sure that we also acknowledge that in understanding intersectionality and understanding health disparities and health disparity populations, as well as those groups that are less represented in STEM, we must continue to remind ourselves of the distinction between equality and equity. And so in layman's terms, the boxes that you see each of the people on in their intent to be able to pick that apple, right? And when we talk about picking the apple, that apple might be a STEM career. It might be navigation in accessing social services. It might be the degree to which they are quickly able to recover or get another job following losing their job because of being ill due to complications related to COVID. Each of them come with something different. What you see in this picture is their height, but in reality, the intersectionality of who they are, based on not just what you see, but their experiences of oppression and prejudice, must be understood through not just community engagement, but community leadership, where they tell and inform the dialogue related to interventions and programs that are effective and that can be sustained. So equity acknowledges what they come with and develops systems and programs that respond to them. And so when we think about income inequality and health, this depiction really just gives you another way to think about it. For those of you who don't know, I hope that this slide introduces to you the connection between the differences in income equity and health. And so we know that, particularly for racial and ethnic health disparity, groups, income inequality has always been real. And if you layer onto race and ethnicity the realities of immigrants or refugee status, sexual or gender identity, all of those things nicely complicate the degree to which income inequality and health are connected. So you can see here that for each of these areas, and none of them include COVID, but COVID is no exception, that experiences of pain management, depressive disorders and anxiety, arthritis, hypertension, and you can see the rest. Where there is highest income inequality, there is the highest reported experience of these health conditions. So yes, not just socioeconomic status of a household, but on a community or population-based level, income inequality impacts that population's experience of poorer health. And so briefly, as we turn the corner in thinking about the problems to the solutions, when we think about and look at the numbers in terms of COVID infections, you can see here, and oftentimes the statistics are focused only on race and ethnicity, but when you layer on pre-existing conditions, When you layer on geography, meaning that there's a difference in experience for people who live in urban versus rural communities, when you layer on immigrant and refugee status, all of these layers of important rich identity shape disproportionately higher risks of not only COVID infection, but also COVID hospitalization and death. And so we've been told, and I urge you to continue to do all the things that we learned to do back a year ago. Wash your hands, watch your distance, and wear a face covering. It is not as easy as that, right? We know that there are social and structural factors that impact COVID risk. I've already talked to you a bit about them. The degree to which people have health insurance is shaped by poverty, income inequality, the degree to which they have paid sick leave. I was just talking to a national group yesterday, and they talked about, the issues of COVID testing and vaccinations, and really implored us to think about the other issues of economic displacement that creates exponentially higher stressors for individuals who are of low socioeconomic status, irrespective of race and ethnicity. And that chronic stress related to structural racism, prejudice, and differentials in power, they all have been exacerbated in this COVID pandemic. So it is not just as easy as those mitigation behaviors. So the Centers for Disease Control and Prevention asked myself and a number of community leaders to talk a bit about our ideas surrounding the path forward. And I want to share some of them with you, again, as we think about leadership, research, and STEM in the path forward. And so I'm going to start with that third pandemic. We are very clear that there are a constellation of stressors that have been triggered by COVID-19. And those stressors are not just related to whether people we're going to contract COVID, but job loss, even being more regularly in a space with one's social and familial network has not always been positive. We know that individuals who are in abusive relationships have been particularly challenged during this time because they cannot go to a healthcare provider to seek solace. Children are not able to engage with their peers in the ways that they did. They are experiencing the illness, death, and hospitalization of those that they care about. And all of those things coupled together are not only resulting in daily life disruptions, but poor coping mechanisms may be developed, or if they were there before, they have been worsened. So when we think about not just things like abusing substances, but even poorer eating habits, less social engagement, all of these things have contributed to increased domestic violence. We know that those, particularly communities of color, prior to COVID, had a 67% less likelihood of diagnosis of a mental health condition. And if they happened to also abuse substances, they were 93% less likely to be linked to or to seek care. And so this was pre-COVID. So in the era of COVID, there is a mental and behavioral health pandemic that is silent again and that we must address. So I want to also make sure that I appeal to those of you who are participating today that have no mental and behavioral health diagnosis. Your mental and behavioral health matters. There is no health without mental health. And you cannot lead effectively if you do not attend to and opine on the realities of how COVID has affected you, whether you contracted it, saw a family or loved one experience it, or just have not been able to be so as socially connected as you were before. I implore you to mind your mental and behavioral health. It is important to you to be a leader that not only lives, but leads and also lasts. So when we think about recommendations, I think one of the most important one when we think about leadership, which is a part of the title of my talk, local community leadership is essential. For those of you who understand the importance of community-based participatory research or any other community engagement strategy, programs and interventions to mitigate COVID or any other adverse public health issue or crisis. Interventions are frequently developed without community leaders, not just at the table in token number, but in the majority to guide and steer approaches based on the lived experience. And so this is the reason why many of them fail, are short-lived, and die when the funding ends. So my first recommendation is to ensure that we flip the script. And that's the script of doctor, whether it's a researcher like me or Dr. Platt, or clinician knowing best, to communities informing us on the approaches that best suit their experience. And so local community leadership should be central when we think about flipping that script of power and prejudice towards those that will be served and experience COVID resilience being at the helm of approaches that work. And so I go back to, or just remind folks of what Morehouse School of Medicine's mission is. Certainly we want to create empathetic physicians that are culturally competent, but at the core of that are the communities that we serve and that co-create interventions with us that work. And so I'm really honored to lead one of 26 prevention research centers in the state funded by the Centers for Disease Control and Prevention. And so if you're ever in the area, please check us out, but I'll certainly include my email in the chat. We are designed and have missions to elevate community leadership in response to obstinate health disparities, but also those that are emerging like COVID-19. And so we have been a community coalition for over 20 years, and I am the we in the minority. The majority of the membership, the leadership, and the voting power is held by community leaders. So that means if I'm proposing a COVID research or response, they can say no to me, and they have in many ways, because as our former and founding chair has always reminded us, that research is really cute, but what exactly is going to benefit us when you get through with it? What are you going to do with the research? And so we've applied this community leadership model in many, many ways. So I'd pause on this slide, and certainly you can reach out to me to learn more about the model of community engaged leadership in advancing health equity. And through the Georgia Clinical and Translational Science Alliance, which is called affectionately CTSA Alliance, Dr. Platt's school, Georgia Tech, is a part of the one for the state of Georgia. But I encourage you to reach out to your state's CTSA if it has one. Each CTSA has a community engagement function. I happen to lead and serve with many others across the state to be sure that research doesn't just go on a shelf or result in funding for academic leaders, but it fosters the translation of research to and from communities, just like COVID, such that it is not something that is informed or steered by researchers, but it is informed and led by communities who are affected or effected by the health issue. And again, I'm focusing on my first recommendation, and that is fostering community leadership. So at the dawn, or at the dawn of COVID-19 back last May, We had an important conversation similar to this one with statewide clinicians and researchers, but more importantly, community leaders that said, I want to tell you how I should be engaged in the midst of COVID. I have many other priorities. Research is not one. So through this, we talked to researchers and clinicians about how they should approach and engage communities, not just as participants in research, but as co-creators, co-leaders of research related to COVID response and resilience. And so another example of community leadership, and I'm happy to share with you the model for this in Georgia, is that I lead and I'm pleased to serve with many others across the state in a National Institutes of Health initiative that's focused to engage communities and promote and facilitate the inclusion of diverse populations in vaccines and in vaccine trials, because there are fewer communities and individuals of color who participate in the trials that will get us to herd immunity. And we know there is a challenge, even though many states have democratized or say they've democratized vaccine access. Many communities of color and those that are disproportionately impacted are able to take advantage of that, even if they have apparent access. The barriers to that still have not been optimally addressed. And see, we are working as a statewide coalition to elevate the leadership of community networks to turn the tide in terms of vaccine uptake. And then finally, we're also working through a community leadership model to address COVID testing. COVID testing is more important now than it was before. For those of you who don't know, vaccines don't cure COVID. They reduce the severity and they have been proven to completely reduce the likelihood of dying and being hospitalized related to COVID. But now more than ever, particularly for rural and urban Georgians who are at risk of or who have diabetes, COVID testing is very important, and community leadership is important in that. So for those academicians on the phone, we have enlisted community principal investigators across the state of Georgia to support and ensure that our efforts are not only statistically significant in terms of our success, but also practically relevant when we think about the communities who are living and leading with COVID risk. So I'm going to skip a couple of slides and go to a couple of final recommendations. Again, we must foster culturally tailored behavioral and mental health dialogue and response. You cannot lead if your mind and your spirit are not well. And the cloud of COVID, the COVID aftermath that some of us are in and others are still in the midst of, require attention to mental and behavioral health, not just for the communities that we serve, but for us who are leading and serving as role models for others. We must attend to our mental and behavioral health. So just yesterday, the New York Times came out with a piece called The Grief Crisis is Coming. And it spoke just to this and said, for each person who dies of COVID, experts say that there are at least 9 newly bereaved, and we have not yet prepared ourselves or really elevated the importance, not just of the conversations, but to decreasing the stigma, particularly in communities of color and other, between the theology and therapy, right? So frequently those two things do not connect. And that's why the issues related to mental and behavioral health, poor mental and behavioral health, suicides, which we've seen on the uptick, as well as domestic violence are what they are. And so we have worked to have conversations where not only do we talk about it, but we also offer mental and behavioral health first aid. I encourage you to participate. It is something that will allow you as a leader in your household or with your students and others to be able to acknowledge, discuss, and refer individuals if you see things that do not look as they should be, and they give you the tools to be able to do that. So finally, what we have learned from the three pandemics, COVID-19, social injustice and inequities that are not new, but have just been amplified per this series, is that we must promote diversity, equity, and inclusion in STEM. And so I want to pause by saying I am looking for a depth in DEI that I think is more important now than ever. There have been many pop-up individuals who have been hired over the past year to be the DEI champion of their organization. And oftentimes, if you're anything like me, those individuals to me are suspect because they have been a quick check off of a box, with one individual being responsible for the diversity, equity, and inclusion of an organization. Diversity, equity, and inclusion, based on what I've shared with you about intersectionality, health inequities and health disparity populations, is all of our responsibility. I'll say that again. Ensuring diversity, equity, and inclusion in ways that are not just about what you see on a Zoom screen. They are all our responsibility. And so Morehouse School of Medicine, and particularly the Prevention Research Center that I'm honored to serve and lead in, has made that our priority to expose, to reduce or eliminate barriers for young people and others who are interested in STEM careers, whether it is the cost of education, the exposure to people who look like them, and those who don't look like them, who understand the importance of promoting and fostering real diversity, equity, and inclusion through sponsorship and mentorship. This is our focus, and I encourage you, if you want to do it and don't know how, we can certainly link you as a mentor or a sponsor. So here are just some closing questions to consider. What are examples of institutional changes? And I mean, whether it is at your business or your academic institution, what are some examples of institutional changes that have been adopted during COVID-19 that have the potential to reduce barriers historically faced by populations? And you can plug in women, the otherwise able population, refugee or immigrant populations, and whatever other layers of identity make them unique, a unique contributor. What have we learned? What changes can we adopt to ensure that those barriers that existed before are reduced, that volume is turned down, and that there is more otherness in the door? How might insights be gained about work-life boundaries, right, during the pandemic, to inform a more prepared generation who are aware and awakened, and as my daughter would say, woke, to live, to lead, and also to last? What can we talk to them? How can we infuse mental and behavioral health as a priority topic beyond math, science, engineering? How do we infuse that as an important anchor or pillar of their education, so they're not just trained with degrees, but also they understand the importance of self-awareness in their mental and behavioral health? And then we have many in the fields of STEM that we want to ensure are enlightened about the connection between science, engineering, the arts, math, and social justice and health equity. That new generation of STEM leaders who have gotten the connection, made the connection per the COVID pandemic and what they've seen, to be enlightened, to not only lead in STEM, but also to be champions for social justice. And then finally, mental and behavioral health. What about that health from the neck up can be used to inform preparedness, not just for how we serve communities, but how we train our leaders to be prepared, to prepare themselves to be important change leaders, because their mental health has been addressed as an important part of their leadership. So mental and behavioral health preparation, the attention to the intersectionality between what we've learned from COVID, community leadership, and STEM leaders that are prepared to advance our thinking from equality to health equity. I'm going to stop there. I hope I have encouraged some of you who are already in the choir, but for those who are not, we really look forward to your questions and comments. I hope I've inspired you on a Friday afternoon, and thank you so much. And thanks to the conveners of this for the opportunity.
Thank you very much, Dr. Akintobi. Enjoyed that. So please, if you're watching, please post your questions to the appropriate spaces where you're watching. I'm going to get to one that's already here, but I wanted to ask my own first, moderator's privilege. So I really resonated with the comment about how words matter. And particularly when you began with saying this, your term of using disproportionately impacted communities versus vulnerable communities. I'm just curious if you could expand on that a bit, but more in the space of how does that, if the words influence policymakers or the affected populations or stakeholders, how do those words and how you frame it change the way other people may perceive the situation?
Yes. Well, I'll start by saying, we all have a lens that we look through. So there's no completely objective term, right? But when we use the term vulnerable, it can connote for some a weakness in, right? Or some characteristic of that population that is less by way of their choice, intention, or priority. So that vulnerability places the onus and the root cause of the issue on them. Disproportionately affected, and when you talk about proportions, you're actually talking about numbers, right? So when you talk about hospitalizations, you can refer to those slides where we know more refugee and immigrant populations, because of those social issues, they're more likely to either be hospitalized, get ill, or to die. Those are numbers and facts, right? Then it puts the onus on all of us as a system, as contributors to fixing that. And so that more objective term and focus on numbers, it doesn't replace all of the social realities that are behind it, but it takes the attention off of the individual to solve it and puts it on us as a system to do so. I hope that helps just a bit. It's complicated, and I love complicated, so I love that.
No, I think even from some of the chat, I think that is a clear way of thinking about it. I want to thank you for that. Going to one of our audience provided questions, this gets to something that I was curious about too. You mentioned near the end about the grief crisis that the New York Times wrote about. And so we have a question from an attendee. So far, my university has not talked about the mass loss we have experienced and how many of us are grieving while being forced to produce. Have you seen any example of institutions that actually address the death and grief COVID has brought? And I'll just add one more piece on that. And how should they, maybe?
Well, I will tell you, just like the person who posed the question, I don't know about you, but in the midst of this being completely virtual, while I have saved time on the road, I probably have been exponentially productive, right? So just wanted to acknowledge the question and the reality of being expected to produce, right? So I've really not had, actually, I was on a call with the NIH earlier today where we were talking about mental and behavioral health and this issue of, the fact that we're not really addressing that. We're just trying to get shots in arms, still very important, vaccinations in arms. We have created some space at Morehouse School of Medicine. So I'm just beginning to talk to colleagues about that part of the pandemic. But we created an arts and reflection space for our faculty last year. And I do have one, I won't say a shameless plug, it was a reality. So we had, a few folks who sang, many of us cried. My brother, who is in a completely different profession, he's in the arts and does some things in New York. He came and played the guitar for us, and people just started to, they had the safe place to just release their emotions. And of course, in most instances, faculty getting on Zooms for the past year, all we've been doing is reporting what we're doing for our students, reporting the grants that we've gotten. It was a space to just be able to release what we were feeling, and no one had to share their loss. But what we had in common is that we were all experiencing it. So in response to that question, it doesn't have to be super complicated, but acknowledging that people are experiencing these things and giving them a space that has nothing to do with the letters behind their name. It's a great leveler. And I think that was something that we've heard from our faculty and students they want much more of, especially since we can't touch each other like we'd like to.
Wow. So if somebody thought that up, was a whole other lane of conversation, but so I just have to pause there for 1 second. Let me just, do that. But let me ask this, and I'll come back to the touchy-feely parts, because I don't want to move faster, because that's what we've been doing, as you clearly mentioned. Now I'm like, oh, I'm gonna ask you another question, but maybe I want to stay in that space. But actually, let me do this though. So I did want to have a follow-up to the grief crisis part also, because you opened up to talk about how some of these other things affect people's health, chronic health issues, and all these other things. I don't know if there's an answer if people have done these studies, but what does the response to grief look like as far as chronic illness, access to healthcare, and all of those other things that come up? Like you did mention the importance of the mental health versus the physical health. Now there's this grief crisis that's driving this other mental thing. Two communities that don't have healthcare, aren't accessing it. How does that then become manifest in the healthcare system? What does that look like in the clinic as the grief is being,
absorbed or experienced? Yes. Well, not so much in the healthcare space, but how it frequently can manifest is in people retreating, right? Mm-hmm. And so that at minimum, even though they can connect, albeit physically distance, people start to be missing in action. And, we've had experiences not just among our faculty, and I say the collective, me and partners both at Morehouse and other spaces, people start to not show up. And so it's not just where not that they're showing up in the healthcare in healthcare environments, but they're missing appointments. So for instance, if they had other health conditions, those things become exacerbated because they're experiencing anxiety or depression and are retreating. And the fear related to that grief because they've lost someone is making them not want to engage with the healthcare system at all. So everything else that might have been happening from the neck down in terms of their health is also getting worse. Wow. So that's a part of the way that it is showing up. But socially, of course, it also shows up in other ways in terms of increased domestic violence, substance abuse. We know that suicide attempts are on the rise. So this is a whole other space that I think we must delve into. And I would encourage Amplified and its partners to really devote a session solely to that. Because I think we need to create a safe space, and not just for the community that we serve, but for us to really talk through that, because this is something we frequently do not want to discuss because we're strong and we're changing the world. So we don't have time. We only have time to produce, but we can't last if on the inside we are falling apart.
Whew. I mean, absolutely. And it's, as we really talk about this grief crisis now, I think what has been made obvious, I think, especially over this last week, at least in my institution, I know at other places, is the COVID breakout in India. And, we all have so many students that are from Indian origin. And just as a touch point, the numbers of families and our colleagues who have family members. And so that grief is now being expanded in like tremendous ways, even as in the United States, we start to kind of maybe see something close to looking like a bright light at the end of the tunnel, depending on what community you're in and where you're from and the rest. So I wonder if you could speak on, I don't have the best worded question, but then now I think that grief is coming back. Like maybe we had a hope that it's going to be over, but then there's now this empathy towards people we know that are experiencing this devastating loss.
Yes.
How to navigate those dualities of mindsets. And if you have any answers, but that's, I think, what some of us are dealing with. Compassion for our students, colleagues, and what they're experiencing, but trying to be hopeful because it's been so dismal previous.
Exactly. No, I think that's huge. And I have a number of colleagues, it's almost like they're where we were last year. And so I think it's really not being afraid. And of course, the fingerprint of any relationship is so unique. So this is not a one size fits all approach, but certainly acknowledging what is happening. And I was just watching something that was actually talking about grief this past Sunday. And they talked about, what not to say and what to say. Frequently, we want to ask, as much as we care, how are you doing? And, how can you ask me how I'm doing? I mean, I just, and they said the better term to use is, how are you doing today? How are you doing right now? That connotes an acknowledgement that something is wrong and I care. But, to expect and assume that people are doing okay. We're in the midst of kind of a space where we have a cloud over us that we're navigating. So how are you doing right now? How are you doing right now? Is an important one potential conversation starter. I can't imagine what you've been through. How are you doing right now? So we have to acknowledge and create that space for the conversations, and they're not going to be easy ones. When you can't even, we talk about not being able to grieve or have a burial if your culture or religion does a burial, but you can actually go to the place or drive by. My colleagues who have loved ones on the other side of the world, they can't even be near them. So we can't expect to really understand what they're going through. It's another level, and we must be empathetic and acknowledge that this is rough. This is hard.
I really like that as a tip of how are you doing right now. Just as a bit of a personal story, like when people ask me how are you doing, I'm like, I'll tell you in 2 weeks how I was doing today, because I've got to figure out what's going on. I don't know. Yeah. 2 weeks, I'll tell you how it was. So I like that. How you're doing right now. That's a question I could answer. We have another question from the audience, and I think this is a really good one too. It's going to have your public health and your Morehouse School of Medicine hat. How would you recommend addressing the constant push to publicly answer whether you've been vaccinated or not, and fearing that I love the smile, and fearing that your answer may impact you professionally if you choose not to answer, or just to say that that's a personal health matter and not answer?
That's a very, very, very good one. I don't know who asked that question, but they may know me, because I'm challenged with that regularly. So in all of our community conversations, we've had about 3 or 4 this week. Some of them are with local churches to collaborate to the CEO of MARTA, where we had a conversation with their entire over 4,000 employees. My position is that we want to give people factual information on why vaccines can help them personally recover. But the intent is to give them the facts in a culturally sensitive way so they can make their best decision when they are ready. So we want to share the science of what works, but our intention is not to try and convert people, right? I start the discussions that way. I say, you may not be there yet. My 70-year-old father is not there yet. I can only get him, he can get there when he is ready. But when asked, I can share that I've gotten the vaccine, but I have many family members, just like their family members who are on different sides of the political aisle, they're on different sides of the vaccine decision. And so just acknowledging that everybody must have their journey towards that decision themselves is a very important way to shape it and create that safe space. But I personally don't feel the ramifications of my personal decision professionally, because again, creating the space for people on whatever side of the decision they are on, or the sliding scale of the decision, let's not say side, is how we start the conversation. You are not wrong for feeling the way that you do. Here is information that will help you in making your decision. Now, we do share some of the facts related to, some newer information that may resonate with some groups over others. So, for instance, there is a 9-fold likelihood of erectile dysfunction following having COVID compared to if you got the vaccination. Right? The fact that young women who participated in the vaccine trials, many of them got pregnant and had children. So all of the questions related to fertility and what people have, the infodemic is what we try to address. But making people feel comfortable where you are is what we welcome. And you're here because you want to understand more. And until you decide to make a different decision, we are here to support and continue the conversation with you. There is a reason why, and going back to the health equity and kind of the determinants of health, there's a reason why, speaking of language mattering, that people are not as confident. So I'm also trying to stay away from the term hesitant. Hesitant, again, suggests that the person is the problem. For communities that have been disenfranchised, that have had less trust of a healthcare and economic system that has failed them, they should want more information before they make a big decision. And any of you who are on the line that are students or scientists, you know that facts matter. The science should guide your decision. So for folks that have been failed by the science or failed by the healthcare community, they have more reason to pause and want more information before they make a decision. That is the right thing to do. It is not hesitancy. So we want to do our best to have community-sensitive vaccine communication. We hope that will impact vaccine confidence and ultimately result in vaccine uptake towards COVID resilience. You see, I said nothing about hesitancy, because again, that puts the onus on the individual versus the system that must be adjusted to get to improve that population's health.
I mean, so I like that wording, but okay, so let me ask this in a pushback kind of way.
Sure.
Okay, because, and I love your approach, but so I get that, how do I want to say this? That I can appreciate that the way you're approaching it is to bring the community in, right? But it does seem to me, and don't want to put words in my mouth, that you would like for everyone to get the vaccine, because then as the public health matter, we'd all be safer if everyone was vaccinated. But I think that what I'm hearing from you is that, but you'll allow the time for people's personal choices. So can you just help me just parse those two? I feel like you want to get everybody vaccinated, but when they're ready. Can you explain that? Or
because, our approach acknowledges that there are reasons why people are not vaccine confident. Because there is a justified reason for their mistrust of the time that this vaccine came online. It seems super fast, even though the research behind the COVID virus, not necessarily COVID-19, is over 10 years old, right? So understanding that people are saying, let me hold back. Let me let you all do it, and I'll see what happens to you. There's a reason why they are unsure. And so the path from hesitancy to confidence requires an unpacking of why the hesitancy is there and helping them to understand why they should consider and be confident. So absolutely, I will say we want everyone to get vaccinated, but the approach of, come on, hurry up, come on, let me get this shot in your arm is not the way. Even if it's the person looks like me, right? And might look like the community being served. Because whenever you're trying to rush trust, it typically doesn't work. There has to be a relationship. So think about any other relationship that you've been in that has been long-term. It requires time. It requires knowing and appealing to what your partner prioritizes and cares about, not what you do. And so we must move at the speed of trust.
Good.
So I hope that helps. I can't say if you don't get a vaccine, you are wrong. People are going to be like, well, you thought I was wrong anyway. I will never engage you again. We must move at the speed of trust. So the safe spaces for the conversations, the science that is influenced by not just the right message, but messenger. All of those things are the formula towards vaccine confidence. So yes, we want people to get vaccinated, but I want to understand where you are and change my approach and my messages. And the messenger may not be B, it may be Big Tigger, like, you know, one of the folks who had some of the conversations with us, he facilitated, and there were more on that Zoom than I could ever get. So I hope that helps, Dr. Platt. It's yes, we want people vaccinated, but if you say, just come on, hurry up and come here and do this, that likely will not always work.
No, and that's why, again, I am not the public health person and I am not a clinician, because that's a different mindset for me. So but I love that wording. And I have been pushing my own family members, but I think my approach has been just get it. And then we have these long conversations what their concerns are. And when I think you make it great, when we can have that long conversation about what they heard, then after all of that, then they're like, oh, okay, well, that's what I was concerned about. So I appreciate that phrasing. But so there's some other questions that have popped up. But before we get to these other questions, I had another piece that I wanted to come back to because you started with it. And I think it's so a part of so many things that you discuss, but it can easily get overlooked. Poverty. And that opening about how poverty hurts. There's such strong data about health-related outcomes in poverty. And I've seen other people talk about just even mental development or being in living in a domicile that has, lead paint or all these other things. That alone can have a greater impact than if people would have strokes throughout their, teenage years and adult life. So I just want to give you a few minutes before we get back to some of the other questions. Can you really just, for this audience, really talk about poverty and the impact it has beyond just what we might see in the common phrase of, oh, they should get jobs, oh, they should do this, but how it really affects a person's being that people may not have a full awareness of. I'd love if you give us some space there.
All right, I appreciate that. So, there is and this is not separate from, a diagnosed mental and behavioral health issue like depression or anxiety. The sociological and psychological experience of lack, particularly for brains that are not fully formed. So I'm talking about children. So there's a reason why I put that infographic there. Is something that is so important to unpack, especially if children are aware that they are living in poverty. I will say, I think I said this as well, is that there are important interrupters that don't make that trajectory towards less excellence or achievement true, right? So I didn't know until I was 12 years old that we were poor. I mean, all that I experienced was our house being full of people on the couch and on the floor. We were always giving. I thought we were the richest family in our community, and then I realized we were not. But there are many interrupters that don't make those statistics necessarily the final decision. But the experience of not being able to do or have things that others do, or to experience a parent or parents who are frustrated, right? Because they can't do everything for you. All of those things children see and absorb and have a different and parallel impact on one's outlook than, say, just being more at risk for diabetes, or to get cardiovascular disease, or not having health insurance. So there's a social and psychological parallel track that poverty creates, that I really look forward to being able to unpack with those who are interested. I have a course I teach on it, but I'm happy to pick up the phone and have a conversation with you on it. So, I want to just acknowledge what you shared, though, about people should just, right? They should just study more, or just, go to get their education. Remember the quality of education, and again, the political investment in schools that are high quality with teachers who are vested. There is a clear distinction of the quality of schools for young people who are in poverty compared to those who are not. The ability to be able to afford a quality education is impacted by poverty, right? The ability, even if you are smart, to be competitive and be in a school where you have a school counselor who can help you to know how to navigate applying for school. Those small things that are huge are things many people take for granted. Their parents should have just, or they should have just. It's a culmination of access and opportunity that are denied of children who live in poverty, and it's separate from any other health issue. So that hurt is not just about physical hurt, but it is also about psychological hurt that can be interrupted by people like us. Whether you are a blood relative, or you are a mentor or a sponsor, our responsibility, and the hour is global. So that means whether you look like a health disparity population, it is our responsibility to be that interrupter that can stand in the gap and make a difference, irrespective of what that child's socioeconomic status or statistics were.
Ooh. So I'm going to pick up the phone. So we will finish this on the phone. So we've got several questions that popped in now. Let me get back to the audience. Thank you, audience. Is it realistic to believe everyone will be vaccinated? Are there facts or science to support that a larger non-minority population is not confident in the vaccine versus the in-minority populations?
Well, what we know is that not everyone is going to get vaccinated, and there are some people who are completely oblivious of what's going on, meaning that they don't watch the news. They may or may not have been affected. There's another group of people that simply will not do it because they're being encouraged to do it. So you may know some people like this as well. I am just not going to do it because nobody tells me what to do. I mean, does anyone not know anybody like that? So I mean, the first part of the question answered, no, everybody's not going to get it. What we also know is that, and I only speak for our state of Georgia, is that individuals, irrespective of racial and ethnic group, who are in rural areas, that's one area we're really working on in our mobile vaccine efforts to go to. The information is not reaching them. So they're less likely to be vaccinated. And we're also finding that older and or Republican white men are also not, right now, they are not convinced. So to the question, it is not just communities of color or those that are otherwise other. But there are other important segments that based on religious beliefs, political affiliation, and keep in mind, I'll say this, I think I might have said it before we went live, the confusion and entanglement between policy and politics that makes some people say, this is who I listen to, and if they're not doing it, I'm not going to do it. So no, not everyone will, and it is not just those who are disproportionately affected by health disparities. So I hope I've answered both parts of the question. We have a lot of work to do.
We do. So I want to build on this, your take on this policy, that piece, policy, politics, and public health. And I'm just curious your take on this. This has been happening in public lately. CDC has been under pressure and people doing this. So we've seen on lots of shows and news things these days about how people are pressured. How do I say that? I'm trying to say this without being biased, but I'm going to be biased. About saying, hey, you don't need to wear a mask outside. Transmission's super low, don't worry, blah, 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 blah. I'll just tell you personally, that upsets me. I'm living in Georgia like you are. We've never shut down. There was never a mask mandate. We are the 51st state in vaccination rate. And so to say like, hey, everybody's fine if you go outside scares me. It has nothing to do with my political affiliation. It's about, I still don't want COVID. And it's just a thing that as a scientist, I'm just curious your take, because there's this public health balance as we're saying about the incentive of giving people vaccinated because then they see how they could live versus living in a space where people are like, I don't think COVID is real anyway. Maybe they say that. So I don't need to I'm just curious your take on these new now statements about, hey, go outside without your mask on, everything's safe. I'm curious your take.
Yes, and this is my take. So I am not speaking on behalf of Morehouse. I'm not speaking on behalf of any other entity. I think that while we know vaccines are effective in reducing severity and the likelihood of hospitalization and death, COVID-19 is still new. And so I continue to advise people to wear their masks, do everything that we were doing a year ago until we have increased the proportion of our population that has gotten vaccinated. I don't think it's time yet to do that. And then you hear people, and of course, some of our community partners, like, I got that vaccine and I got COVID. Yeah, you can still get COVID, but you won't die and the severity will be lower. But what you don't know is the other health conditions of the people around you that have not gotten vaccinated. And they also have to know that if you don't wait a certain period of time after that second dose, you are not fully covered, right? So for all of those reasons, and because COVID-19 is new, I advise people, let us continue to do what we are doing. But you have done something that when you consider the alternative, a sore arm for a day or two, greatly outweighs in terms of a better decision, not just getting COVID and recovering, but we know now, we're working on some studies among long haulers. There are people who have gotten COVID and recovered that have new health issues that were not there before. And those health issues are not just physical, but also psychological and behavioral. Which one would you rather?
So again, I love how it's your words, and I love how your words very specifically are the vaccine reduces severity and risk of hospitalization, as opposed to how that message changed differently. I like you were very particular with the wording. So we have another question from the audience that really wants to go back to your DEI talk.
Yes.
And you almost dropped some hot buttons there. Then you let it go, but you said about all these new people taking on these. I'm going to leave that out there in the space, but this question is different than that, but I caught that and you didn't say a lot there, but we can come back to that later. But about your comment about DEI work is everyone's responsibility. I think that resonated with the audience. But do you have advice on how to approach this in the workplace? Sometimes feel like it usually falls on the few BIPOC, Black, Indigenous people of color to bring awareness to DEIs, and then that can get someone coined as the difficult one.
Yeah, I only had 40 minutes, so that is not because I didn't want to dig in. So I'm glad you brought it up. I'm glad you brought it back up. So, there also is, because I found myself and others, navigating these waters with many of my colleagues and friends who mean absolutely well and were so impacted and affected by the events related to George Floyd and the social injustice connected to COVID, et cetera, there is a weight, and not a positive weight, of being responsible or being the designated educator for everyone else on issues related to social injustice and health equity. And so, as a part of the Prevention Research Center network, we actually had our network meeting yesterday, and it was on racism and social justice. One organization, one of our prevention research centers, talked about their model of addressing not just DEI, but what's behind that. And those are issues of prejudice and power differentials, et cetera. And they got the question, first of all, was the group a required, was it a required kind of committee, or did people have to participate? For that particular organization, they said it was not a requirement, but certainly there was increased participation this year, given everything that's been going on. And then the other question came up, so who leads it? Each staff person is required to rotate leading the discussion during each meeting to really address and ensure that there is not the designated individual who is required to open the conversation, be responsible for the dialogue, and also be responsible for having all the answers. It is a global and national issue, and if you bring that kind of blanketed experience, we must blanket the responsibility and the safe space for discussion, such that every member of the organization has a place to be able to share what they're experiencing, whether they are an individual of color or not. So that requires, I think, real sensitivity, even among those of us who are a part of communities of color. We also must create the space for those who may be new at this, right? But also require that they have the courage to be able to own that DEI and addressing social injustice is something that is an opportunity and a responsibility, not a weight, for all of us. So I gave you a practical example of how one organization is creating the space and the requirement for leadership that is shared. And that's something that, at Morehouse School of Medicine, I kind of take for granted because we're in that space all the time. But what are the DEI opportunities for us? When we think about maybe not having as much representation in terms of the otherwise abled community, or not having as many men who should be a part of the conversation. So we all have a unique opportunity to really do some self-reflection on how we are ensuring integration as well as diversity, not just by token people, but a culture that invites it. And creates the space. When we lean into discomfort, we know that's where real innovation and opportunity comes. So it's not just DEI to have a title, but we are to be going towards a certain destination. Things should change, and it requires discomfort.
I thank you for those suggestions. Those are, I think, even in the examples, I think those are things that organizations could put into place that are tuning in. So we have another question that is a little bit, obviously related, but a little bit different space. So how do we rebuild trust with our communities when the field as a whole refuses to acknowledge or atone for all the horrors that science, medicine, government has inflicted on communities of color? And this questionnaire specifically lists examples: forced sterilization, medical apartheid, experimentation. But I would also add in, and even kind of building on your last answer, racism in the academy, racism in medicine, yes, racism in all these things. All of those things have been inflicted on communities of color. How do you go about rebuilding trust?
You can't, and again, if you just think more generally about relationships that you care about, there's some of us have heard the term, there's no way out but through. You have to talk about it. This happened. These things happened, and they were atrocious, um, horrible experiences of men and women. And they were not just men and women of color, they were the disabled or mentally disabled community. And all of it at its root was about power and those who had more power or less power, whether because of their color, status, background, etc. Uh, and so what we try to do at Morehouse School of Medicine and within the Prevention Research Center, we have a module that's focused specifically on bioethics and community engagement, where we talk about and really unpack, because a lot of people know there were atrocities, but they really don't know the details. They just know it was bad. And so we unpack, this is what happened with this group, and this is why it created mistrust. And then we talk about how different administrations, particularly Clinton, when it came to things like Tuskegee and others, really worked to federally not only require atonement, but to create systems such that these things do not happen again. So a part of the understanding of why research is stronger is not just because there's more representation by people like us, but that's a part of people also understanding what is an institutional review board and what does that have to do with me, trusting you more as a researcher, as a clinician. All those things happened, and now we have rules of beneficence and all of these things that IRBs require so that we are accountable and can be eligible of your trust as a community resident. So these are ways to connect not just the horrible things that we must continue to discuss, but say how science and research boundaries have been developed so those things do not happen again. And then here we are as people who are saying we want to not just see if you're eligible for our research studies, but first, we want to be sure that we maintain our eligibility of your trust.
Come on. All right, listen. I love the way you frame things. I love the way you frame it. It's going to be uncomfortable for research, but I love the way you frame that. So I'm going to ask one final question from the audience, then I'm going to close out with one more question of my own, just so you get the sense of as we close out for time. But the audience question is, how would you recommend setting boundaries and expectations of that shared educational grace when you talk about DEI for non-people of color or people new to the DEI space if they are the ones appointed to lead that DEI space? So really getting that boundaries and expectations as they learn more. How would you recommend they go about doing that or setting up those boundaries?
Say the question one more time.
So how would you recommend setting boundaries and expectations of that shared educational grace for non-people of color or people that are new to the DEI space if they're the ones appointed to lead that new DEI space?
Oh my goodness. It's always good in the beginning to have and anyone who's in academia may appreciate, I hate consultants for the paperwork side of it and getting stuff through the system, but it's nice to have external perspectives or facilitators in the beginning. And even for the discussion we had with the PRC network last week, we had a champion of social justice who happened to have been Caucasian and another one who was not, right? And so they represented kind of external voices that could bring some objectivity, meaning that they were not a part of the system, to kind of help to facilitate the discussion so everybody felt safe. And so I think that that is an important investment if an organization can do it, so that both, people of color, but also those who are a part of majority groups can still feel safe in their, acknowledged, first grade or, not knowing as much, but with the intention to do better and to know better, because it's very sensitive. It's very, very sensitive, and everyone should feel protected in their quest to do better. And the truth is, we all have room to do better.
That's fantastic. So I'm going to come back to one of your other points that you brought up just to close us out. So about art. So the other side of my world is theater, creativity. I love music, art, music, all these things.
Yeah.
And I love how you said one way that you all created a healing space was just to have people together and just art, music, singing, whichever. I find comfort in poems. You know, at the Atlantic
Yes.
magazine sends out poems for the Times, and I like to forward those to students. I just would love it if you would just close it out. You know, as science people, numbers crunch, you know, the quantitative math side versus the art side. But art is so helpful to help understand what we're thinking and relate to others. I would just love it if you could just give a little bit more oomph on the importance of art or the helpfulness of art, even as we are in these, you know, being counter kind of communities. I'd love it.
Absolutely. Absolutely. We have to feed all the sides of who we are, and you know, we have one temple that we produce, live, and lead with. But in order to last, we have to infuse elements that may not necessarily be our major strength area. But I am clear that music is medicine, and the
Mm,
arts really are have an opportunity, give you an opportunity for an outlet to be able to unpack, to celebrate. Sometimes it's the opportunity to be able to go back to a safe, you know, happier place. All of us have that part in us, and it may actually help, you know, you navigate this era that challenges your mental and behavioral health, to expose yourself, and not just turning on the radio in the car. I mean, that's nice, or when you're working out doing other work, but to really allow yourself the space to listen and appreciate the arts in ways that allow you to opine, reflect, and to download what you're experiencing. It is therapy. It's absolutely amazing. I was a music major my first year in college, and sometimes I regret not going back to that, but now I'm starting to be able to do the things I want to do. So I strongly advocate it.
thank you so much. Ladies and gentlemen, this is Dr. Tabia Henry Akintobi. We thank you for your words. We thank you for your message. And I really thank you for your words because the words matter. And I think you made that clear. Thanks again for joining us, to the audience, for another Gladstone Amplified series. The next one will be coming up in June. I think they put in the chat, will be advertising. But again, I want to thank you and look out for my phone call because we have some more to discuss. Thank you, everyone. Be safe. Have a great weekend.
Bye bye.